So again, hello and welcome for this CML Foundation's key discussion on CML in Africa, the second of a great series for 2025. My name is Oliver. I'm a hemato-oncologist, originally from Germany, but since many years working in Tanzania at the Kilimanjaro Christian Medical Center. This is where I'm greeting you from. And I will be your moderator today. And before I introduce our speakers, I will take a moment to let the newcomers to the foundation who don't know ICMLF yet to know something about the ICMLF work. So what is the ICMLF? The ICMLF is a physician and researcher-based foundation with two key priorities, both working towards improved outcomes for CML patients worldwide. Now, firstly, they are raising the bar of CML management through CML education, and that includes meeting like our meeting today. Over the last 15 years, the foundation has been working via preceptorships, in-person meetings, and online with our case discussion forum, which many of you know and participate in, and also the Knowledge Center, trying to make sure that no matter where you are in the world, CML physicians and researchers have access to the best possible knowledge, opinions, and experience. The other side of ICMLF work is harnessing the power of global research. The ideal is working towards a cure for CML, but along the way, they are trying to improve treatment pathways and patient outcomes as much as possible. So they have the Genomics Alliance, they have the Treatment-Free Remission Alliance. They did lots of work around CML and COVID back then. There is also a hepatitis B survey, which rolled out recently. And they're also looking, put a focus on CML and pregnancy in low and middle income countries, which we had also discussed in earlier years again, and pediatric treatment in low and middle income countries. And there's much more to come. That's just a brief overview of the International CML Foundation, who they are and what they do. And please reach out to them and to Aline, who has sent you the invitation link for today, if you have any questions or want to know more about their programs. So for our discussion today, we will start with the topic of overcoming challenges to adherence to treatment. And then later we're going to switch to CML and pregnancy in a resource-constrained setting. So let's jump into our first topic for today. And this is overcoming challenges to adherence to treatment. And I'm very delighted to welcome, and you're also not the first time on this meeting, of course, Dr. Amma Anima Benneh-Akwasi from Accra in Ghana. And Amma is an eminent physician and CML lead in Africa, who is also a great friend of the ICMLF Foundation and a co-member, just like myself, of the Foundation's African Steering Group. So Amma, thank you so much for joining us today, and very welcome. And then for the first block, I'm also very happy to introduce Dr. Daniela Zackova from Czechia, from Brno University, another internationally recognized CML physician and a significant contributor to the Foundation's study of the impact of COVID-19 and CML patients. But also you did a lot of research in treatment-free remission and quality of life, which I was recently encountered this on the German Oncology Conference, where some of your work was presented as well from other speakers. So thank you very much, both of you, for joining. And now we are looking forward to listen to your first case, Dr. Amma, and the stage is yours. I will stop the screen share from my slides.
Thank you very much, Oliver. Good evening, good morning to everyone. It's a pleasure to be here. Thank you, ICMLF, for inviting me to share some thoughts on adherence. Thank you. So thank you very much. We'll go straight to it. The outline will be some introduction, factors contributing to non-adherence, strategies to improve adherence, case summaries, and a conclusion. So the advent of BCR-ABL tyrosine kinase inhibitors have caused a revolution in terms of management of CML, transforming a fatal disease into a chronic and controllable one. The achievement, however, hinges on sustained adherence. I'm sure you all agree with me. Unfortunately, up to 1/3 of patients are non-adherent to their prescribed TKI regimen, resulting in suboptimal molecular responses and inferior long-term outcomes. In the current era of treatment-free remission, where discontinuation of therapy is possible after achieving and maintaining a deep molecular response, adherence has become even more crucial. Thus, suboptimal adherence not only compromises initial treatment response, but may also preclude patients from ever reaching TFR eligibility. What are some of the factors that contribute to non-adherence? There are treatment-related factors, patient-related factors, system-related factors, and I'm sure you're familiar with some of them, if not all. So when we're looking at treatment, we're looking at the effects of adverse effects, inconvenient dosing. Sometimes you have to wait and, for example, in nilotinib, it has to be on an empty stomach. And then, of course, the patient may have a number of other drugs, to take. And when it comes to patient-related factors, we do have the socioeconomic barriers and sometimes poor understanding of the disease, and to some extent, denial, by the patients. You'd have some psychological, cultural, and societal influences, lifestyle changes, and then perceived wellness after remission. I mean, once you're told you are in some form of remission, you think that's it, there's no need to take any drug. System-related factors, inadequate patient-provider communication or follow-up, lack of structured adherence programs, and limited access to diagnostic monitoring capabilities. And that plays a very important role in our part of the world. Some of the strategies, you'd have to look at monitoring, regular review of pharmacy refill data. They want to see whether the person is keeping appointments. If the person misses and comes to tell you, I still have some of the drug, then that is the red flag. Then frequent monitoring to identify suboptimal response. Of course, support and education, you can't hammer it enough. The establishment of peer support groups, continuous patient education, counseling, psychological support, and actively managing treatment-related side effects and comorbidities. We also need some healthcare system interventions, strengthening clinician and patient relationships through trust, open communication, and shared decision-making, and to also see if we can establish structured nurse-led follow-ups. I'm sure you agree with me that sometimes patients will tell nurses what they won't tell you as a doctor. So we have to use that as well as a strategy. So the first case is Mr. J, a 29-year-old male who was diagnosed with CML in November 2018, following an incidental finding of leukocytosis. And this is a full blood count picture at diagnosis. We realized the white cell count was 85.16 times 10 to the power 9 per liter, with an increased platelet count and a BCR-ABL transcript level of 34%. So he was commenced on imatinib and achieved hematologic remission within a month. At 3 months, his BCR-ABL was 27, signaling suboptimal molecular response and triggering the first adherence counseling. He subsequently defaulted reviews in various periods, and after comprehensive counseling, restart of imatinib, was started, and he remained compliant. However, the reason for his non-adherence was a strong belief that imatinib was causing infertility. And this concern became paramount following his marriage amidst significant cultural and societal pressure to procreate. The clinical implication was that this reveals a profound conflict where the patient perceived his life-saving CML treatment as a direct threat to his personal and familial goals. His decision to prioritize potential fertility over disease control demonstrates how deeply health beliefs and societal pressures can override medical guidance. The intervention, patient's compliance improved after empathic counseling. This case highlights the importance of providing proactive and ongoing counseling aligned with individual life goals. So the points for discussion: male infertility and chronic myeloid leukemia. Is it disease related? Is it therapy related, or both? How best can one deal with it? The other would be, how best can one tackle cultural beliefs and perceptions when they contribute to non-adherence? Thank you.
Thank you very much, Amma, for this first case. Very, very important. And this is what we also encounter here on the other side of Africa, in East Africa, very often. This question about fertility in both in male and in female. And this is one of the reasons we encounter a lot for non-adherence. May I ask you, Dr. Daniela, to comment on the first case and to give your view on this and maybe some experience from Czechia?
So thank you very much, Oliver, and thank you, Amma, for this very interesting case, which illustrate, as was mentioned, several important aspects, especially like important or relevant to middle and low income countries. Like, it shows that non-adherence is rarely just about forgetfulness, as we usually perceive that it may have much deeper personal, social, and cultural roots. And at the same time, it also demonstrates that ongoing counseling restored adherence here. So regarding issues with potential infertility, we know that, especially with imatinib, it is probably not the case. So, but currently, in Europe, we have new incomers like asciminib, and the experience is quite limited. So we sort of keep asking the patients if they want some kind of fertility counseling or sperm banking or something like this, especially in young patients. And I think that and what I perceive, that young patients are quite often managed in Africa, especially. So this is not recommended strictly, and it is not even written in current recommendations. But what I discussed with Elisabetta Abruzzese, and it will be probably also discussed later during the second topic, that also she sometimes do it. So maybe if there is some such strong pressure from society and from family, and we can see that it was really like the survival was traded with some kind of to be accepted by family, by society, to have kids, to be. So maybe this will be also like one possibility how to improve, but I am not sure if what are the possibilities regarding this particular point, like fertility counseling, sperm banking before starting TKI therapy in your region.
Yeah, in Ghana, they are available, but of course, they are expensive, And I must say that when it comes to people living with CML who are men, a lot of them have been able to father children, But this thing is so sensitive and personal that even if one person, is not able to do so, it's a big deal for that person. And so I've just been thinking myself, should we do a blanket, if you're male, should we offer them the opportunity at least to get baseline sperm counts, and then as therapy goes on. But it's costly, and most of
It's
our
costly.
patients are out of, job because it's taking quite some time to actually know exactly what is wrong with them. So it is possible. It will come at a cost. So probably we can offer that. Yeah.
Yeah.
I think also from our experience here in Tanzania, sometimes it helps to make a plan to say, look, we need to put you on a certain time frame of imatinib, and once you reach deep molecular remission, we can think about a treatment pause, for example. But it's a very tough discussion, and I see in our chat also from the colleague, I'm sorry, I hope I do pronounce it correctly, Lydia Ngolet, and a guest from Congo, and she said counseling will not work when it comes to pregnancy. So it's a very huge pressure from the society, and I guess the only thing I think is really we need to do counseling because we need to work together with the patient to find a way. She also mentioned, and I want to bring it up to you, Daniela and Amma, is fertility. She says fertility, pregnancy, but also adverse events from upset stomach to hypopigmentation are in the Congo remain reasons for non-adherence to treatment. So maybe, Amma, you can also comment on the hypopigmentation.
Precisely, it is. It is. And in fact, when it comes to counseling people who are going to be on drugs, for life, it's not a one-time thing. You just have to keep going at it. Because TKIs have a role in the melanin production, at some point, that's a standoff. And so the skin starts lightening up. And so people get to know, and unfortunately, they attribute it to skin lightening, So they will think that you are intentionally using stuff to make yourself look lighter. And also, it leads to questions. Why are you getting so fair? What is the problem? So when I get patients, the initial talk is about the fact that you're going to get light-skinned and you have to weigh the risk and the benefits. Everybody has something that he or she is dealing with. This is a lifesaver. So it doesn't matter if people make a lot of remarks about the way you're looking, but it's important that you take your medication to keep alive. So yes, I agree. So on day one, we tell them, you're going to get lighter. And with time, they tend to accept and take their medication.
Maybe if I can add, I totally agree, and really adverse events are really an issue. So what we can do for patients, to discuss with them very honestly the situation, but we also should provide the new data. We know nowadays that we can quite safely reduce dose after achieving of very good molecular response. We have data supporting it. So no fear about like resistance if we are going down with the doses. We can also stop treatment, but we know that it is still only minority. So maybe I would more like emphasize possibility of dose reduction, and many or majority of side effects are, I'm not sure about this hypopigmentation, because I'm talking about all other side effects. Many of them are dose dependent, so we have to also stress it for patients just to keep some period where the drug intensity is crucial from the beginning, and then we will trial everything possible to make their life with TKIs much better. This is one point. And also we know that, especially with imatinib, some kind of, or many of side effects are sort of settle in time. So also we should tell the patients, encourage them, try to have a very trusting relationship with them, and try to encourage them, because some adverse events are really there, and it's difficult like to avoid them, especially at the beginning. Mm.
Thank you very
I
much,
agree with
Daniela.
you.
If I have one question to this, when would you consider a dose reduction at the earliest point? When would you
At the
say,
at,
okay, yeah.
Yeah, I'm getting more and more brave. I mean, with coming data. So currently, when we have, well, I mean, I keep first year like trying to be intensive also with dosing, and like taking care mainly about the disease, but of course also of adverse events, trying to manage them with supportive care, etc. But then if we have major molecular response and even deeper molecular response, I'm now quite proactive. Today I had my outpatient clinic, so I propose dose reduction in every single patient, because yeah, it's getting much more safe, important part of management. And as Amma mentioned, the majority of them will be on drugs until the end of their life, so we should do it. So after achieving of MMR, but especially with some second gen TKIs, you Oliver are probably aware about Dasahi trial and some other kind of trials with starting dose reductions. So now we, for instance, like adopted some kind of approach suggested by French colleagues to adjust the dasatinib frontline treatment dose based on therapeutic drug monitoring. So we are starting with dose reduction quite early based on plasma levels. So yeah, I think that it's getting much more active, even from maybe also even when the response is not as good as I mentioned, maybe even before achieving MMR. But to be more safe, especially for patients after achieving of MMR, it's quite safe. And every time we can increase the dose if the response is again getting worse.
Thank you very much. This is very reassuring that we can also deal with dosage reduction once we have achieved a molecular response, or a deep major molecular response. Please, I also see the other questions from Lydia and Goulet about like you have in your experience from 79 patients, only 12 have achieved deep molecular response with imatinib. This reflects, by the way, a lot of data from Africa, but this, I think, deserves a different discussion on the reasons for this. It's not only adherence, I believe, because as we know that many African patients, they are diagnosed very late, like similar to the late stage presentation we see in solid tumors, and may have already accumulated a lot of resistance mutation and additional apparent cytogenetics. But this is a very important point, and I'm sure we will also tackle on this in one of the other meetings. And then there is from Michael Mauro. He just commented the dose reduction are more justified on second generation TKIs. I guess Daniela mentioned it also, such as the dasatinib, imatinib dose reduction below 300 may be subtherapeutic, and this can pose a challenge. That's what he said in the chat. Would you maybe as a last answer respond to this, Daniela, before we move to the second case?
Yeah, I basically agree. We are going a bit more below, so 200 milligrams. But yes, there are, I mean, different opinions. And again, if I can see that the patient's starting losing the response, I can increase the dose quite safely. So yeah, basically, I agree with Mike. Yeah.
Yeah. Okay. Thank you very much. And so let's move to the second case, Dr. Amma. And please.
Thank you, Oliver. So the case 2 is Miss G, a 27-year-old woman with pre-existing type 2 diabetes mellitus, and diagnosed with CML in October 2023 after a month-long history of progressively worsening splenomegaly. So these are the parameters from the full blood count with a BCR ABL transcript level of 14.27%. So she was started on imatinib in December 2023, achieving rapid hematologic response. Sorry, something is happening here. Okay, so by April 2024, the counts started rising, and it indicated that there was a lapse in adherence. This was promptly addressed, and with resumed regular dosing, hematologic remission was reestablished within 2 months. She, however, defaulted again. Upon patient engagement, she cited an increased appetite from imatinib as the primary reason for her non-adherence. She perceived this side effect as the direct cause of her worsening glycemic control. The clinical implication here, this reveals a critical therapeutic conflict between her CML treatment and diabetes management. The patient's self-directed treatment interruptions demonstrate how managing multiple chronic conditions without integrated support can lead to poor outcomes for both conditions. So a coordinated referral to endocrinology for an adjusted diabetic regimen to resolve the conflict between her cancer treatment and metabolic health was done. And this case exemplifies the necessity of a multidisciplinary care model to manage the complex interplay between treatment and comorbid conditions. So the points for discussion, apart from education, which other ways can one employ to overcome non-adherence? The impact of comorbidities and side effects on adherence to therapy. Thank you.
Thank you very much, Amma, for this very interesting case as well. And I would just like to give directly to Daniela to comment on patients who have diabetes at the same time or a pre-diabetes. What do we need to consider in these patients, and how do you manage those?
I mean that this is not only about diabetes, but about many other chronic diseases. Currently, also CML is like really a like proper chronic condition. So now we have to deal with co-medications and other such situations. So I'd like also highlight the new ELN recommendations where the like multidisciplinary approach is emphasized. So we should definitely like cooperate with other colleagues, other specialists. Sometimes we can I can personally like encounter situations when my colleagues, even in the university hospital, they are really the leukemia is stigma, no matter what kind of leukemia it is, and they do not want to treat such patients. They like consider they like completely hopeless disease, etc. So I think that we should improve it with personal communication, some leaflets, also some I mean interdisciplinary seminars or like such events to improve the situation, because it's really quite often, and I can imagine also that in Africa it will be probably an issue, and especially with diabetes. We also made some research, and we showed that with nilotinib, and it's very well known that it is really like problematic drug, but otherwise other drugs are quite safe in this situation. So again, to explain the patient, to communicate with his physician who is taking care about diabetes, and try to persuade them, or him or her, that it is like nothing bad, nothing no negative correlation, or yeah. So just again explain the reality, provide data, and try to manage it.
Thank you very much. This is a strong advocacy for the cooperation between the specialist, the hematological doctor, hematologist, and also the maybe general practitioner. And this is also what, again, Dr. Ngolet said in the chat. She said different providers should co-see the patient appointment on the same day, sharing lab reports so that the patient does not repeat blood draw for the same test, and paying attention to drug interactions as metformin and tyrosine kinase inhibitor, for instance. I think that's a very, very important point to keep in contact and to discuss with the other healthcare providers. May it be the general practitioner in let's say in the European setting, may it be also a health center or dispensary in a more African setting, where we always need to give informations at hand to the patient, how to deal with the side effects and what is need to know about interactions. Amma, what is your take on this, and what is your experience in communicating with primary healthcare providers in Ghana?
Yes. Yeah, it's been good, but just Daniela said, sometimes some people think that leukemia, that's it, you can't do anything about it. So usually you identify one or two people who can actually understand what you're doing, and then you just tell them, I'll just keep coming to you. But then education is also important. What I've also been doing is sometimes we get people from all over the country, and so I tell them, if you go to a nearby clinic, you can give my number to the doctor and we can discuss your case, so that it's something that can be done at his end. We could collaborate, and manage some of these side effects and comorbidities. And I found that to work. You do get people who are actually interested. So the take will be, yes, education, try and identify 1 or 2 people who are interested or want, to get involved, and then just keep the education going until you get some more people in your network, so to speak. Thank you.
Thank you very much. And again, Mike also mentioned, I always try to engage with patients to adjudicate symptoms and side effects that are first CML related, second treatment related, and thirdly unrelated, with the optimism that once in remission, CML symptoms are likely limited or not present, and to be careful not to allocate most or all the symptoms immediately to the TKI. Also, the disease itself and other unrelated side effects can occur. And he then said also, I echo Amma's comments on collaboration. Many providers are unfamiliar with TKIs and may assume the worst. I can echo this. We are working with primary healthcare providers here in Tanzania in early detection of CML, but also in treatment steering, so also to reduce a lot of traveling, and it's working very, very well if you train, if you give good training and good education on chronic leukemia.
Oliver, thanks. I feel like it's like as if I have laryngitis and you have to speak for me. Thank you for.
Yeah, please feel free. More easy.
No, yeah, Amma, that's great about, passing the collaboration, in the US, we're able to find specialists too, cardiovascular specialists when we have maybe a particular drug concern or risk. But really, it's just basic communication with the primary providers, and the patients themselves can't, it's hard for them to understand maybe sometimes who to ask about a side effect or a problem.
Yes, we're just spotting the signals. Yeah, spotting the signals, mixed reviews, complexion changes. In fact, that's very true. When somebody comes and the skin is darkening, then you know that you stopped the drug. And then starting the conversation, and then shaping the solution, tailoring interventions to individual barriers, and then staying connected. And we usually also take the opportunity on CML, World CML Day to have some webinars and some patient meetings, just to get feedback and give them the opportunity to talk about it. And sometimes when they do, other people may be having the same side effect, and so they get a clue or two as to how to manage it. And at least they get reassured that they are not the only ones doing it. So there's a nice flow chart here that we can do to try and improve adherence. Thank you so much.